Okay, evening everyone. Morning to Dr. Dusek and Professor Po-Hyung Chang. It's 7 in the morning and it's 8 in the evening, Monday evening. Welcome to the KMCRIC webinar. I'm Hyang-Suk Lee. I'm the host of this webinar. I work in College of Korean Medicine, Kyunghee University, Seoul, Korea. Well, I looked over the registration list and we've got about 36 researchers, 29 clinicians, 18 graduate students, and 4 undergraduate students and others. I believe that everyone in this webinar is highly interested in clinical research and practice-based research in particular. So nobody told you to join this webinar at this time on Monday evening, right? So it's all voluntary. So thank you to all. Originally, thanks to Dr. Chung-Bae Park's help, Dr. Dusek was supposed to come to Seoul and give a talk at the International Congress of Oriental Medicine in 2020. But unfortunately, due to COVID-19 pandemic, the Congress was postponed and next year it was canceled again. So I've come to think that why don't I invite him to give us a talk at an online seminar? I'm happy that he accepted my invitation, and thank you, Dr. Dusek. Now, everybody is familiar with online meeting and familiar with sharing slides, so it'll be perfect to having him at an online event. So, and it will be much better to introduce him and his research to a larger audience in Korean medicine researchers community, what the BraveNet PBRN is and what PRIMIER is as the sort of like best practice example of studies from practice-based research network, PBRN, in Korean, 개원이 중심 연구망. So let me briefly introduce Dr. Jeffery Dusek. It's from Google. Okay, can you see my slides? Yeah, I'll be introducing you in English, but it's in the same content is in Korean. Jeffery Dusek is the Director of Research at University Hospitals, Connor Hall Health, and an Associate Professor in the Department of Family Medicine and Community Health at Case Western Reserve University. He received his PhD in biopsychology from Stony Brook University, New York in 1996 and completed postdoctoral training at Boston University in cognitive neuroscience in 1997. He has over 20 years of experience leading innovative integrative health and medicine research at prominent research and healthcare institutions in the US, such as the Beth Israel Deaconess Medical Center, Harvard Medical School. Dr. Dusek has also been a leader of the BraveNet practice-based research network, and today he's also going to talk about the PRIMIER Patients Receiving Integrative Medicine Interventions Effectiveness Registry, one of the BraveNet's most ambitious projects to date, for which Dr. Dusek is the principal investigator. His research has been published in prestigious journals such as the Journal of the National Cancer Institute, Circulation, the PNAS. I asked him to give a 40-minute presentation, and later we can have a Q&A time. I also asked Dr. Seung-Min Lee for translation at Q&A sessions. So everybody, please feel free to ask anything, both in Korean or English, okay? So Dr. Dusek, could you please share your slides?
Absolutely. Thank you for the wonderful introduction. And again, my apologies for it being so late in Korea, but we found a way to make it work. So I'm to be talking to you today about the BraveNet practice-based research network and PRIMIER as introduced. And thank you to the KMCRIC for the invitation. So BraveNet is the first US-based practice-based research network focused exclusively on integrative medicine and health. We currently have 17 members including 3 members of the Veterans Administration, which is the largest healthcare company in the country. We were founded in 2007. We've expanded in 2 waves to 17 centers. We have ethnic, racial, and economic diversity. We look for actively funded researchers, and we look for geographic range across the US. I'll make this a little bit smaller for you all, so my screen don't get cut off. There we go. As you can see across the US, we have a preponderance of people of centers in the East Coast and the West Coast. We're looking to expand a bit more in the center part of the US. You can see the listing of the centers, including some prestigious centers like Duke University Integrative Medicine. We've got Osher centers at San Francisco, UCSF, UCSD. And as of July 1st, Connor Whole Health in Cleveland and the University of California, Irvine, Susan Samueli Center will be taking on leadership. So the coordinating center will be in California, and from Cleveland, I will be directing the research. So I'll be the overall principal investigator. And this just shows that we are now collaborating. This is a press release showing that we are now switching the leadership from Albert Einstein University in New York to University Hospitals and University of California, Irvine. BraveNet, we've been publishing papers over the past decade. We had a registry that we put together back in 2007. And from that, we published 5 different papers looking at why individuals select integrative health and medicine, that individuals who select integrative health and medicine have higher stress, pain, and psychological symptoms, looking at specific conditions like gastrointestinal diseases, as well as cancer, as well as body mass index, so people with more obesity. So looking at a registry, it was a one-time registry, unfortunately. So there was only one time of data collection. Since then, we've also published how integrative medicine is being used across the US. We've published a small prospective study looking at pain patients over time, over a 6-month period. And then finally to the most ambitious project, which is PRIMIER, which was this was a study protocol published in 2018, where we talked about collecting data over 17 centers across time. Before I get into PRIMIER, I want to just go through briefly the phases of research. So this might be familiar to you, where we started with bench science, and then it translates to the bedside, where we have controlled observational trials and phase 3 clinical trials. And the overall goal would be to deliver the right care to the right patient at the right time in clinical practice and identifying new clinical research questions. This idea of going from phase 3 clinical trials into clinical practice is a very big leap. And this is a paper that was published in the Journal of the American Medical Association a number of years ago that talked about practice-based research being really important, the intervening step between the big trials and practice. And this is where we have observational trials, we have survey research that could help us to enable us to understand and help us to even understand how those randomized trials can impact clinical practice. Another way to look at this is how the NCCIH, the National Center for Complementary and Integrative Health of the NIH, talks about their research questions, going from basic and mechanistic research, where how does it work, to the very far right bubble, where it's still effective when implemented in the real world conditions. And so my talk today is going to be focused solely on the purple bubble, namely in the real world. So we're not going to have a comparison group. We're going to see how these interventions are used in the real world. And one of the big things that we've learned from clinical trials is it might be that 8 weeks of acupuncture improves outcomes for osteoarthritis if given 8 weeks in succession. But in our clinics, patients can't get that same kind of treatment. Namely, there may be a wait list for 6 months, or they get treated every 3 weeks, or they go on vacation, or they're sick. So what happens when the 8 weeks of acupuncture aren't 8 weeks in succession, but might be over 4 months or 6 months? So again, getting the idea of practice-based research is pragmatic and looking at how the real world interacts. So PRIMIER is as introduced, was patients receiving integrative medicine interventions effectiveness registry. So the idea is to collect information as individuals are encountering our clinical environment. So we enroll patients with the idea of evaluating the changes in patient-reported outcomes, in this case, quality of life, mood, and stress over time. At some point, we were looking, I'll speak more about that today. We're going to look at demographics, clinical condition, pain interference scores, and integrative medicine intervention sought in more detail in future studies. But today, for the short talk I have, I'll focus mostly on the change over time. And then ideally, in the next 6 months or so, we'll be able to understand how specific interventions differentially impact PROs over time. So the idea would be to look to see, does acupuncture deliver better outcomes for pain versus massage or chiropractic care? But today's purpose will be really focused on objective number 1. As I mentioned before, we are 17 centers. This is a non-randomized prospective observational evaluation. Patients, or in this case participants, complete measurements of patient-reported outcomes at enrollment, which we call the index visit, 2 months, 4 months, 6 months, and 12 months. And the idea why we call it enrollment or index visit versus baseline is sometimes patients have been receiving care for us or with us for a period of time. So when they enroll in PRIMIER, they may be at the start of their treatment, they may be a little bit more into their treatment course. What we do is we have them complete that information via electronic means, and then we use the electronic health record to get their services that they received, the diagnostic codes, and the codes that talk about the billing. So the idea would be to compare or have at our disposal patient-reported outcomes as well as diagnostic information from the medical record to understand who we are caring for, namely cancer patients or fibromyalgia patients or other conditions, as well as what they received in our clinic. And the overall goal of PRIMIER is to assess the real-world delivery of integrative interventions across settings and clinical conditions through patient-reported outcomes and electronic health record data to examine associations with improved quality of life over time. So inclusion criteria include they being seen as a clinical patient, participating in integrative medicine within 60 days of recruitment. So we want to make sure they were actually a patient and they weren't just coming by to test out the clinic, because that might not be the best participant. They provided informed consent to participate in the registry. They had to be 18 years of age and older, and then have electronic health record data with at least 1 visit to us within 12 months. So the data includes enrollment, patient demographics, including alcohol, tobacco use, nutrition, exercise, use of opioid medications, patient-reported outcomes, which is called the PROMISE. This is a standardized way to collect information about how patients are doing. This is a typo, actually it should be the perceived stress scale, not the PROMISE perceived stress scale, the patient activation measure, primary condition and diagnosis, the interventions received in our clinic, as well as new patient status. The PROMISE, which is 29 questions, has 4 questions per what we call construct or area, including pain interference, the ability to participate in social roles, anxiety, depressive symptoms, fatigue, physical functioning, sleep disturbance, as well as a single item pain intensity scale on a 0 to 10 numeric rating scale. So again, we also include the perceived stress scale, which has got 4 questions on perceived stress, going from 0 to very often. And so we get a scale of their current perceived stress. We also get a score of their patient activation. So there's a 13-item validated questionnaire that looks at, the patient's assessment of knowledge, skills, and their confidence to manage their own health. The score goes from 0 to 100, and you can divide patients into 4 progressively higher activation levels. Level 1 is a score of 0 to 47. They do not believe they have a role in their active or important role in their health. Level 2 is they lack confidence and knowledge to take action. Level 3 is they're beginning to take action over time. and level 4 is maintaining behavior over time. So again, this is very important because as you'll see in a moment, a lot of the PRIMIER participants are already at level 4. They have found our clinics, which are consultative clinics, and they're already maintaining behavior over time, which is why they're seeking out us. So just a caveat to who our patients are. Again, we're looking to collect information about mind-body, acupuncture, manual therapies, chiropractic care, integrative medicine consult, coaching, as well as energy therapy. So we have 7 different categories of care. Again, the electronic health record data is their name, their date of birth, as well as their payment type, description of what they received, and the description of the kind of patient they are, namely cancer or orthopedic or other kind of condition. So PRIMIER, we enrolled over a year and a half, no, actually 3.5 years, sorry, 4,883 participants. We did lose some individuals who had no visits between their index visit in 12 months, who had no electronic health record, had no data on what they received, and no dates of service. So we have 4,043 with a complete electronic health record data. 413 of those individuals had incomplete patient-reported outcomes. So we lose some people there. We get to 3,958 individuals with an index survey, as well as integrative health information. From that, when we combine that with a survey, we get a total of 3,658 individuals with index survey, CIH visit data within the 12 months. This is not within the 12 months. We lost about 35% who did not complete an additional survey, but leaves us with a very large cohort of 2,374 individuals for whom we have data where they have an index survey and at least one data point at 2 months, 4 months, 6 months, or 12 months. So specifically, we had individuals, 1,700 complete individuals at 2 months, 1,448 at 4 months, 1,400 patients at 6 months, and almost 1,500 patients at 12 months. So again, a very large cohort for a real world registry in the US. The characteristics between the patients who were in our cohort and those lost to follow-up, again, show a little bit of slight difference where it's a little bit slightly older in the cohort, a bit more female, a bit more racial white than we had seen. We lost a few of our racial minorities, including Hispanic. The BMI is a little bit lower, so maybe a bit healthier, and the education level is 78% had education. So the people who stayed within the cohort are a little bit different than the lost to follow-up, but we're not that concerned that they're that different. Again, working full-time, it's a little bit lower, so they may have more time to participate in the surveys, a little higher percent of marital status, less individual, people with a bit more means, a bit more means on the wealth spectrum. And then again, individuals who have private insurance, it's a little bit lower, actually a few more people on what we call our public insurance, called Medicare or Medicaid. But again, these are statistically different because the samples are so large, but again, not that different with regard to important outcomes. So one of the interesting things with our baseline characteristics is 41% of our individuals, this was their first proper visit to the clinic. So they had something beforehand, but this is really their first, they weren't quite what we call a drive-by, but they were brand new to the clinic receiving treatment. 86% report using some kind of therapy in the prior 6 months. So that's one of the tricky things with integrative therapies. One can either practice them on their own, receive them from private practitioners, or come to clinics. So again, people in this case were relatively new to our clinic, but had practiced in these, had some experience before coming to our clinic. On the Promise 29, this is nationally normed. So a 50 is the national mean with a standard deviation of 10. So you can tell in the mental health summary score, our participants in PRIMIER were about a half standard deviation below the national norms. And the same thing with the physical health. So they're actually having some challenges both mentally and physically. The composite score talks about this is all the symptoms, and in this case, they're about a half standard deviation above the national norm. So these are individuals having some kind of complaints, which is why they're seeing us. And specifically, the complaints are anxiety, which is about a half standard deviation above the norm, not so much depression, fatigue, some sleep disturbance, pain, and physical function. So anxiety, fatigue, and pain are three of the areas where we're seeing more difficulties. Perceived stress, the national mean is about 4. So we're seeing these individuals are reporting a higher level of stress. And then patient activation, I mentioned before that we go from levels 1 to 4, and you can see right away, over half of our group is already saying they're trying to maintain behaviors. And between level 3 and 4, about 75% of the population is either taking action or maintaining behavior. So these are individuals who have found our clinics already doing something to help their health and well-being. So they're very motivated. So key takeaways is our cohort is more likely to be female, older, white or Caucasian, educated, of normal weight, married, have a higher income, have public insurance, and have visited the clinic before and reported services in the past 6 months. So just a context for who we're studying. When we look to conditions, about 19% of individuals present with chronic pain, acute pain about 10%. One of the interesting things is some people, it might be those level 4 people, are coming in for what's called a wellness visit. They're coming in not for a condition, but they're saying, I'm just trying to keep my health at a level that is sufficient. And again, you can see 5% anxiety, 5% cancer, and of course, some different some conversations. These are self-reported symptoms at that index visit. You looked at diagnoses with the electronic health record, it's a little different. And again, sometimes patients and the medical record don't always agree. But you can see, we looked at our medical record, about 30% are in for pain, 12% for lower back pain, chronic fatigue, 10%, hyperlipidemia, 7%, heart disease, myalgias, wellness visits, et cetera, excuse me. So you can see it's a little bit different with the electronic health record when you ask people differently. So we do sometimes we call triangulation. In our cohorts, we'll look at either what a patient reports or what's in the electronic health record. And this is very common in patient-reported outcomes in practice-based research networks. So again, one of the things that's interesting is when we look to our electronic health record, we can see exactly what people have received over time. This is a bit of a busy slide, but let me just focus on, for example, the highest percentage is going to see either a physician or nurse to consult about their care. So between that index visit in 2 months, about 46% of the individuals in the whole cohort have received that kind of care. Oops, my computer is dancing a little too far ahead of time. So we can see the consult is the highest, acupuncture second, manual therapy is third, chiropractic care fourth, all the way down through. And so you can see in that first period of time, about 75% of individuals have some kind of service. And then as through the whole index to 12 months, 100%. So you can see mostly it's a higher percent in the early part of the index, even though it wasn't necessarily the reason why they were coming to the clinic. And you can see that decreases over time as people might be having some relief in their care. So again, it goes from 75% to 52% to 43 to 58. But all told, all individuals have to have at least one visit of one of these services from index visit to 12 months. And you can see again, the top 3 are consult with a provider, acupuncture, and manual therapies. And again, this just talks about the median and the range. So the range can be very dramatic, where in this case, one individual had 39 provider consults, one person had 79 acupuncture consults, and one had 61 manual therapy. So the range is, the median is 2, 4, and 6 over the 12 months, the lowest part is 1 and the highest is 64. So it gets very skewed because some people are coming quite often over 12 months to our clinics. So what do we see on these outcomes? So the index visit, these are changes from the index visit. So there's no change in index visit. We're seeing that people on the mental health summary score at 12 months or 2 months are reporting 1 unit better, up to 12 months at 2 units better. So we're seeing actually an improvement in the scores going from index visit to 12 months on the mental health summary score. And this is a composite of things like depressive symptomology and anxiety. On the physical health summary score, not as dramatic an increase on the physical health summary score. And this is actually becoming more common where integrative therapies tend to have a bit more of an impact on mental health than necessarily in physical health. I think we're seeing over time. Now, if one is only getting acupuncture or manual therapies, I think that does translate. But as you saw just briefly, a lot of what we do is consults with our patients, namely, can you eat better? Can you sleep better? Can you take more opportunities to improve your stress? The composite score, this is all the different symptoms, namely anxiety, depression, fatigue, pain interference, and sleep disturbance. And you can see when you combine all those, we're getting a very nice improvement over time. Not quite linear, but you're seeing a progression that speaks to this improvement. When you look to anxiety, it gets even a little bit more pronounced where we're getting almost to 2 units. Depression, same thing. Fatigue, same thing. So you've seen that same kind of pattern where there's no difference, obviously, at index because that's the same score, excuse me. But by 2 months, we're seeing a pretty nice improvement, and then it seems to progressively improve over time. Pain interference, again, this is not a cohort that has a preponderance of pain. Like I said, it was only 17% were coming to see us for pain. When we look at a chronic pain cohort, you'll see a dramatic difference. I'll show you a chronic pain figure in a moment, but you can see about a 1 unit difference in pain interference. Perceived stress, this is a much shorter scale, so the improvements we expect, and we're hoping to see about a 1 unit improvement, and so we're getting that about 12 months. And patient activation, this is a scale going from 0 to 100. So again, a score of 3 or so is actually clinically significant. So about 12 months, we're seeing, even in our patients with high levels of activation, we're seeing those scores improving over time pretty dramatically. So key takeaways are we're seeing statistically significant improvements at 12 months, mainly with a P of 0.001 on 6 of the 7 PROMIS scores, including mental health, physical health summary scores, the composite score, as well as the perceived stress scale and the patient activation. Specifically, anxiety and fatigue subscales, the mental health summary score, the composite score, and the physical health or perceived stress scale were all improved at all 4 time points. So again, quite a nice improvement. So this is adjusted means we're looking to see at 12 months. So we're looking to see, are these double asterisks, namely, is that adjusted for age and sex? And we're seeing mental health, we're seeing a very nice improvement on physical health, composite score. Oops, my apologies for my computer is jumping. The composite score, anxiety, depression, fatigue, sleep disturbance, pain interference. We're seeing very nice changes over time that are quite impactful at the P.001 significance level. And again, just another way to show this, if you look to the score at 2 months, at 4 months, at 6 months, at 12 months, we're seeing improvements of about 0.7 units, up to 1.64 units. But again, all very statistically significant. And this shows the same data in a different format: mental health, composite, anxiety, fatigue, and perceived stress scale. Now, one of the concerns is with a large sample size, we know that statistically we can see changes. So we know that we're seeing these wonderful changes over time. But I like to think about, what about a minimal clinical important difference? So we define this minimal important difference as 3 units or 3 points better than index score at a given time point. Because statistically, with a large sample size, you can find those improvements easily. but for a person on an individual basis, if they improve by 3 units, they are then considered a clinically important improved individual. And so at 2 months on the mental health summary score, we're seeing 30% of individuals meet that threshold, 45% at 4 months, 34% at 4 months, 34% at 6 months, and 38% at 12 months. So again, on the mental health summary score, which is probably our best indicator of overall health, we are seeing over a third of the individuals are responding at a clinically important difference at 12 months. And when you look at this compared to other integrative medicine clinics or other conventional clinics in the US, that's a very important, that's very comparable to what we're seeing in conventional care. So we know that patients who have clinical challenges have a tough time responding. So we're getting a very nice response that's very indicative of what we would see in other conditions. The overall clinical composite score with the symptoms, it's a little bit less, 27%, 29%, 29%, and 33% are hitting that threshold. So again, statistically, we're seeing wonderful differences. Clinically, we're also seeing very, very important differences. So across all the PROMIS subscales and the summary scores, we're seeing a common pattern of percentage change of responder increasing from 2 months to 12 months in that follow-up assessment. So again, that's also indicative that we're seeing some improvement that might be cumulative. Again, we have to do a little bit more analyses, but we're seeing what might be a linear relationship of changes over time. Another way to show this is, again, the same kind of data. I highlighted previously 30% up to 38%, as well as the pain interference. You can see reliably we're seeing changes that are improving over time with a changing sample size, of course, but by the end, we're seeing some cases up to 40% of individuals are meeting that clinical threshold of a clinical improved difference over time. Again, one of the ones that seems to lag is the physical health. And again, it might be a function of just the types of patients we see or the interventions they're receiving. So again, that is something that we're keeping an eye on, that physical health tends not to jump up as much as mental health. But again, when you look across all the spectrum, we're quite happy with this pattern of results. So summary of findings is we had almost 5,000 participants. We had 3,600 fully complete patient-reported outcomes at the index visit. About 65% completed at least one follow-up assessment, had electronic health record data, and had a visit within 12 months. They're mostly white, female, college-educated, with a mean age of about 51 years of age. Chronic pain, acute pain, and wellness were the most common conditions. We saw significant improvements at 12 months. And again, meaningful improvements were found on mental health and physical health summary scores at 12 months. Limitations are, we did have a 65% retention rate. That means 35% of the people dropped out. And again, that's not uncommon for practice-based research where people are in the clinic. We actually have them self-enroll via tablet computer in the clinic waiting room to enroll. And we send out emails to them at 2 months, 4 months, and 6 months, and 12 months. So we do reach out to them via email to collect that information, but people sometimes stop coming to our clinics or don't find the surveys are that useful to them. So one of the things we want to think about is how do we improve that retention rate? And can we provide some information to our participants to increase that? Now, I will say my colleagues and I just completed a survey or a systematic review of information of patient-reported outcomes that will be published in the Journal of Integrative and Complementary Medicine, where we find that 65% retention rate is very common for practice-based research evaluations. So when we are not involving patients in clinical trials, but involving them in watching them as they undergo their clinical care, 65% retention rate is pretty common. One of our issues, though, is limited diversity. I mentioned Caucasian, of some means, and not as much diversity as we'd like to see. So our next efforts will seek to increase demographic diversity. We know African Americans, Asian Americans, and other ethnic participants would be important to have, just because that is something that is important to ensure that we have representative of the US population. By design, we had no comparison group because that was what we're studying. There are some ways that if we have the right clinics and if individuals in all the clinic complete these surveys, we might be able to have a comparison group of individuals who don't use integrative therapies, who might just receive conventional care and complete the same questionnaire. So our future works will be looking to expand our clinics to see if we can enroll individuals outside of our integrative medicine clinics as a comparison group. But by design, PRIMIER was not to include a comparison group, but it is one of our factors in the future we'd like to do that. And then finally, patients might be receiving care at PRIMIER previously, so their index visit might not have been the actual start of their treatment course. So future studies will include both individuals, some studies will include only at the start of their actual treatment course, and other studies will mirror what PRIMIER is doing, namely, we don't care what they're receiving, we want to assess what they're doing over time. One of the tricks with the US at least is there are a number of integrative medicine clinics, so people might be new to our clinic in Cleveland at university hospitals, but have been receiving care at Cleveland Clinic, the same kind of treatment. So because they're new to our clinic, doesn't mean they're new to the field of integrative health and medicine. So future directions are to include assessments specifically for patients with chronic pain and lower back pain. We also want to perceive analyses to see if certain interventions and modalities and doses offer reductions that might influence pain, depressive symptomology, and stress. We're currently working on that, but not ready for analyses yet. We want to explore whether individuals or combinations of therapies are associated with larger outcomes. So for example, do individuals who have integrative health plus chiropractic care do better than people that just receive chiropractic care? And then finally, I mentioned before, we want to analyze potential relationships of dosing and timing. So does dose make a difference? Or does timing make a difference? So for example, you saw that some individuals had only one dose in their 12 months. Clearly, that's like the minimal important dose. Some had up to 79 sessions. So again, looking at this idea of dosing, does dosing actually influence their influence on patient-reported outcomes, as well as the timing? So for example, I mentioned in the preamble, some individuals have care that might be in randomized controlled trials, 8 weeks of acupuncture in 8 successive weeks. In our time, we're actually seeing oftentimes the difference between next visits is about 8 to 10 days. So does that, and sometimes people have a gap between interventions of 2 months. So again, can we provide some information to clinicians and patients suggesting that a shorter duration in between interventions could be beneficial? I wanted to also, just because I have about 3 minutes before we'll start the question and answer, I wanted just to quickly go through our chronic pain cohort, and I'll go very quickly. This is where individuals who are showing on this scale, this is how much did pain interfere with your activities? How much did pain interfere with your work around home? How much did pain interfere with your ability to participate in social activities? How much did pain interfere with your household chores? So again, when people ascribe they have a chronic pain condition, here are the outcomes we're looking at, these pain interference outcomes. It's a little bit smaller. I'm going to go very fast just because of time. It's a little bit smaller than the 2,337 or 374. We had about 1,000 people in our chronic pain cohort. We did lose about 37%. And they're about the same age and conditions as we had seen previously. Again, I'm going to go very quickly. The one thing I want to show you is their pain interference score is about 62. So again, they have more anxiety, they have more fatigue, and they have more pain than our overall cohort. And they have more stress. And again, far fewer are maintaining behaviors. Again, I know I'm going very quickly, but I wanted to give you this opportunity to see this chronic pain cohort. Again, they're seeing more, we're seeing they've ascribed themselves to have a chronic pain condition, and we're seeing well more chronic pain conditions. They also have other issues like sleep, anxiety, and depression. So very quickly, again, they all have to receive at least one integrative therapy. It's a little bit higher use that we're seeing in the other cohort. And again, it ends up being consults, acupuncture, manual therapies. So again, just very, very quickly, my apologies. But what I wanted to show you was this. With over time, we're seeing actually a very significant increase or decrease, excuse me, in pain interference in that chronic pain cohort. So again, where it was more modest in our more heterogeneous group, the overall PRIMIER, when you look just at the chronic pain patients, we're actually seeing quite a bit of relief. Fatigue is going down, anxiety is going down, sleep disturbance, depression, the overall score. Mental health is actually quite improving, which we're pleased about. Physical health is still that challenging area, and then perceived stress and patient activation. So again, just want to show you very quickly, when you look just at a chronic pain cohort, we're seeing very similar, maybe more pronounced changes on pain interference and the mental health cohort. So again, my apologies for going a little bit over with the presentation, but I want to give you a sense of, in our biggest cohort, we are seeing some really important constructs. And again, I'm just going to go quickly to this is redundant. What we're seeing here is the big issue is, or the big opportunity is, when you look to the minimal important difference for, this is pain interference, about 43% are reporting a clinical important difference at 12 months. So it goes from 36 to 43. So the take-home message from PRIMIER is, while the overall cohort is very important, I think the real value add is we start looking at specific patient populations. So when we start looking at chronic pain, we are actually seeing a more impactful impact of integrative medicine than if you look at a general integrative medicine clinical population. So again, what I wanted to show you this is a major improvement where almost half of the individuals are reporting clinically important differences at that 12-month period. And again, you can see the same thing with composite score about 40%, 43% for mental health, anxiety 40%. So again, much higher numbers than you saw just a moment ago. And I think that's because we're focusing on a specific cohort where pain is an issue. So when you start looking at symptoms that are challenging at the beginning, we actually find an opportunity for more impactful differences. So again, summary, it's still the same white female college educated, but we're actually seeing really more pronounced improvements. One of the things we want to do is to look at the Veterans Administration, because we do have the same information across sites. We want to increase a larger number of sites, more diversity, and then looking at dose. And again, the collaborative team, this is never done by, this is the writing team that's coming up. So we look at all the individuals who spent time writing this, again, looking from the Osher Center at Nashville down to Einstein Corning Center. So again, I thank you for your attention. I appreciate that this was in English and I do speak quickly. So I'm happy to entertain any questions you have. And thank you for your attention at 8 o'clock, almost 9 o'clock at night in Korea. Thank you.
Thank you, Dr. Dusek. It was very interesting and insightful presentation. 여러분들 다 잘 들으셨을 것 같고요. 박종배 선생님 오셨네요. 안녕하세요. 그러면은 제가 그 translator를 구했거든요. We've got a translator, Dr. Seungmin Lee. So you can ask any questions, either in English or in Korean. So feel free to ask anything. I mean, the results are quite impressive. I mean, especially the pain patients quote, right?
Mm-hmm. Mm-hmm. Yeah, we are very happy with that. It's especially, you note that the patients are coming in with quite a bit of pain. And what is not clear here is oftentimes these patients have been through conventional care for months and months and months, if not years. So they finally find us and are finding some relief. So one of the things that we are happy about is that some patients have been suffering for many years are finally finding some relief.
Mm-hmm. Can I ask you, how how did you define the clinically minimums? I mean, different.
Sure.
At over 3 points for any subscales.
So the promise, so it's the patient reporting, it's the promise
Patient
scale.
reporting.
Yeah, with the promise scale, it's a U.S. standard deviation, U.S. mean of 50 with a standard deviation of 10, and the individual who developed the individuals who developed this identified 3 units as a clinical important difference. So they talked to patients and they used other measures and said, what's an important change for patients to report? And anything 3 or above that makes a difference to patients. So when we set that threshold, we're seeing, like I said before, at 12 months with the chronic pain cohort, about 43% are saying they're reporting this is an important difference. So that's why we're really happy with that, because statistically we have such a large sample, the p-values always get big and always look good. So that's why we really look to clinical important difference.
Right. Yeah. Significant improvement.
Exactly.
Right. 우리 채팅창에 들어오는데요. 질문들이요. 이승민 선생님 이거 하나씩 좀 해주실 수 있을까? 뭐 이렇게 질문 많이
sure.
길어.
There's so many questions on the chatting room. I'm gonna have to try to translate this as fast as I can. So Professor Zhang, he actually asked, said, thank you so much for your very thought-provoking informative talk. And the research results and the information will be very important to understand, especially the progress, prognosis, and the natural history of patients that visit the clinic, especially for the first time. Especially because we are so short of clinical data in this area, and we just don't have any information on this. So thanks again for this research. And he was especially impressed with what you showed at the MCID index with PROMIS 29, because that was something that is not well known. But of course, you talked about this as well during your presentation, that the limitation was the lack of control group, especially in pain research, especially to figure out the effectiveness of the CIH. I think that is a very, very critical limitation. However, of course, in the future, we believe that there must be a well-designed study with a control group, just so that we can kind of eliminate any to negate any what other researchers might think as a short research. So do you think that you did tell us a bit about gathering information on what the control group could have received? Do you have any future plans on how to further maybe improve this limitation and to find out the effectiveness of CIH in the future?
Yeah, it's a great, absolutely. So, and we're happy to note that the intent of PRIMIER was to only study integrative medicine clinics. So one of the opportunities, if conventional clinics were to include the PROMIS 29 in particular as part of routine clinical practice, that would afford a comparison group. The trouble is not many clinics in the US routinely collect that information. And so what we'd have to do is find a partner clinic that has the same type of data collection. And so what happens is, it's tricky because there was one study that was done at Osher, Harvard, that looked at chiropractic care in 200 individuals who went to a conventional clinic versus 200 individuals who went to a integrative medicine clinic. They found significant differences between the chiropractic and acupuncture care versus usual care. But there's still a self-selection where some individuals would never think to go to an integrative medicine clinic and only go to conventional. So what we really have to do is to find a clinic that has both integrative and conventional, and they're going to the clinic, but they may choose the pathway of receiving just integrative therapies or just conventional therapy. So any which way we use a comparison group, there's going to be a complaint that we're biasing only because of the natural the self-selection of patients choosing a therapy or not. Does that make sense? So again, what the randomized control trial allows us to randomize people to receiving, let's say, acupuncture or usual care. So that provides the best control group. I think what we're finding is in our real world studies, we're noting that almost dosing becomes our comparison group, namely those individuals that receive very few doses versus those that receive more doses might be a better comparison group. So again, looking to say, everyone's choosing to have integrative therapies, but we recognize there's a dose component that leads to a better outcome. That's where we think actually a better comparison group will be than individuals who only receive conventional care. Only because of this a bias between some people will never receive integrative therapies. I hope that's clear.
Could you please summarize in Korean?
제가 해야 돼요. 강의
해야 됩니다.
오케이. 그래요?
아주 간단하게.
근데 그러면 여기서 핵심은 그거였던 것 같아요. 실은 이게
네.
쉽지 않은 거는 다들 알고 있고 한계가 있고 다른 연구에서도 많이 했었는데 그러니까 시도해봤는데 쉽지 않다는 거는 가식 결론이었고 근데 오래 연구를 하다 보니까 이 침 용량, 침이 아니라 이 CIH 용량이 오히려 신기하게도 약간은 대조군처럼 역할을 하더라라는 게 이제 좀 핵심이었던 것 같아요. 그래서 오히려 한 번만 맞는 그룹이 있었고 아니면은 뭐 여러 번 맞는 그룹이 있는데 이 둘의 비교가 어떻게 보면은 오히려 약간 대조군처럼 역할을 해주더라. 근데 이제 물론 그 특히나 EHR 레코드를 받을 때 모든 정보를 다 받기는 쉽진 않아가지고 뭐 그 대조군에 취합하는 게는 역시나 말씀하신 것처럼 쉽지는 않았다 이거였고 그 향후에 이런 연구에 관한 그 계획이 있는지는 답변 안 해주셨던 것 같아요.
네, 그리고 그 또 물어보신 것 중에 레드캡이거든요. 레드캡을 사용한 거 데이터 컬렉션 그 툴에 대해서 좀 그 질문 장보영 교수님 질문 마저 해주실래요?
Okay, yes. So another question from Professor Zhang was that it seems like you used Red Hat as a
No, Redcap.
Red Cap. Oh, it's a Red Cap. Okay.
Yeah.
So the first question was, did you use Red Cap as your tool? And number two, were there any issues while you were gathering information or gathering the clinical data? Were there any hardships or issues that we can't see in the papers?
Good question. Yes, we did use RedCap. And one of the challenges with RedCap is we were using email to contact individuals for the 2-month, 4-month, 6-month, and 12-month. We now are using, we're planning to use text messaging to that because it's going to be much easier for people to click on the link in a text message. So Twilio is an opportunity for us to work with RedCap to be able to, I think, collect a better set of outcomes or less dropouts because emails are easy to ignore.
Right. Yeah, text message will be more practical in Korea as well.
Yes, exactly.
Yeah.
And the second question, Dr. Lee, I'm sorry,
were there any hardships?
Hardships. Well, the hardship was definitely losing people to follow up because they just didn't look at their email. As we found, RedCap emails are easy to ignore. And I think we're all becoming worldwide now more of a texting society. So I think that's going to be very helpful. I think the other thing is it's challenging for people that don't have the resources to go to our clinics. So some are paid for, quite a few are paid for by insurance, but some individuals don't have enough money to pay for our therapies. So we realize that the hardship is that it can be costly for some individuals, and we are trying to bring our therapies to places where individuals without money can receive the services. I can give an example. You can translate, and I'll give you a quick example of what we're doing about that.
Sure. And then another question, was were there any hardship with the IRB? But do we have time for another question from Dr. Zhang?
Sure, of course. The IRB, actually, there was no issue with the IRB. We did actually, when we started the study, the US IRBs did not allow for people to enroll electronically over by themselves. We had to have a paper consent form. And so the regulations did shift. I had to have probably 8 or 9 conversations with IRB administrators to say, it is part of the US federal regulations to allow people to self-enroll in the study. So every site had IRB approval. We had also IRB approval for our overall coordinating center. So it just took them a little bit of time to realize that people can self-enroll.
Oh, wow. So you had to get IRB approval from all the institutions? Wow.
네. 장보영 교수님 또 어쨌든 거기 질문 감사하고요. 넘어가도록 하고요. 여기 채팅창에 여러분들 다 보실 수 있는데요. 여기 C라고 되어 있는 분 질문을 받을까요?
Okay, so there was another question on the chatting room, and thank you for a wonderful talk. In the observational study, the effect over time might include placebo effect or regression to the mean. And did you compare the effects of the different treatments? And it will be more useful information if you could suggest the best treatment from your data.
We're working on that. Absolutely. We appreciate regression to the mean is also an issue. And again, that's why a comparison group of sorts, and I think dosing is probably the best way to do that. And we are looking to see, we're in the midst of looking to identify, are there particular treatment patterns that are more effective? I was not able to show you we have a heat map of what individuals received individually over the 12 months. So we actually look at several cohorts where some individuals received acupuncture all the way through the 12 months. Some were more sporadic. So I appreciate the question. The next questions are dosing and interventions for the next level. This was the high level presentation.
Next is 김희경 선생님 질문 직접 해주신다고 하셨어요?
네, 제 목소리 들리시나요? 네. Professor Dusek, it's my honor to attend the lecture, and I'm really glad to know that MTID was around one in every 3 people. The MTID level was higher. I'm glad to know that. And my question is, promising and feasible as it sounds, I also see some differences between 개원의 중심 연구, which means private owner clinic, and what you have envisioned and you have done in your PRIMIER registry. On that, one thing that sticks out to me is that all of the 17 BraveNet member clinic listed in PRIMIER registry are all institution-based or run by universities. And as an would-be researcher who are currently running my own small clinic, I can easily imagine that if any researchers outside of institute or university, if they want to perform any research, they would have to kind of face more hardships and challenges than their counterparts in universities. So my question is, could you give some advices to individual researchers who run their own mom and pop clinics and also serious on research? Thank you.
Of course. Actually, one of our centers is a mom and pop. So it's a small clinic in Cincinnati. It's a great question. I've been asked this question a number of times, where REDCap is a tool that you have to be part of the club, essentially, which is not great. I recommend that people, even using, I know it's a little bit odd, but paper and pencil questionnaires can be helpful to collect information from your patients. The PROMIS scales can be collected through a different electronic means. So there's this group, not called a REDCap, but assessment center, that would allow anyone to collect that information. So I feel like even if you're a small clinic, collecting this information can be very useful. In fact, I think it could be a way to document improvements in the patients you're seeing, to feed back to the patients also that their improvements are important. So that was actually one of the questions in the chat room. In the chat was, do patients or colleagues receive this information? And in PRIMIER, we did not provide information back to the patients or the providers, the colleagues, but I think it's actually very important. And so one of our next efforts would be to almost randomize people to, some would receive information about how they were doing relative to themselves previously and the national norm, and some wouldn't, because I think that would be also very inspiring to say, the changes I'm making and the care I'm receiving is actually improving myself, because they answer the question. They kind of generally know if they're doing okay, but they don't necessarily know how they're doing. So they saw that they were, let's say, a 47 on the physical health, and after 6 months of acupuncture, we're now a 52, and they knew that was better than the national norm. They might be inspired to continue receiving care. So I think data collection, any way you can do it, if you're a mom and pop, is important, because I think I think data in the hands of the provider and the patients and the researchers is useful to proving what we're doing. And again, I know I'm definitely criticize no comparison group, but knowing that, as I said before, even with the comparison group, we do worry about people self-selecting the treatment. So I think the question of a comparison group is going to be, it's more useful for a randomized controlled trial. And so I think that's where we're moving. We've done randomized controlled trials. I'm actually working on one where we're doing acupuncture in the emergency department at 3 places across the US in the ER. And we're randomizing to usual care or acupuncture with the idea of looking to see, does acupuncture reduce acute pain and narcotic use? And that is where we have a comparison group. So right now in the midst of doing that at 3 BraveNet centers across the US in preparation for a definitive study. So I fully appreciate regression to the mean. I fully appreciate that we don't want to take credit for natural history. And I appreciate all the very good questions thus far. But that, I know it's kind of a little bit jumbled, and I apologize it's in English, but I hope that was clear.
Thank you, sir.
Okay, as far as I know, Promise 29 was translated and validated in Korean, so
yes.
you can use it. Yeah,
yes.
right.
Yes.
Maybe we can talk about it later. Okay, 그 다음에 최선미 박사님, 최선미 선생님.
Yeah, we have a lot of questions from Dr. Choi as well. So the first question was, is it possible to collect or insert Promise 29 directly using EHR? If possible, can the data get saturated enough to get to the point where we can extract it for research and directly run it for statistical analysis? Or do you need to collect the data separately as a survey and code the results during research?
It's a great point. So in the US, we have the PRIMIER medical record is EPIC, EPIC, which is our medical record. We just had a call with them 2 weeks ago, and they're now embedding Promise 29 and other measures in the electronic health record. So we're seeing more of that where it will be really embedded in the clinic, in the medical record, which can be useful for, as anyone comes to the clinic, any clinics, they could complete those. And that's where I think that's where the goal would be. Primary care clinic, if they collect that information in the same kind of time frame, we can compare those outcomes to the integrated medicine. And again, that will help us to understand the regression over time. That will be the comparison group. It's just that a lot of health systems in the US have not adopted this data collection thus far because it hadn't been easily embedded into electronic health record. So yes, that I think almost allows that comparison group where it's not integrative medicine clinics, but more broad-based clinics. I think it's just been slower because the health system doesn't always appreciate the use of patient-reported outcomes, but we're making strides.
Also, Dr. Jongdae Park asked if you could share the challenges of your PRIMIER study, which might be helpful for Korean sites. Is that?
Absolutely, sure. So the challenges are loss to follow-up, people dropping out. I think people ignore red cap emails. The challenge of diversity or lack thereof. I think we want to make sure that we are representing the whole US. And I think the other part is really to understand dose and preferred modality we need a bigger sample size. So even with 2,300 individuals, we probably need 10 times that to really dissect the different, which if acupuncture is better than massage or chiropractic care. So PRIMIER was, although it was our intent to be bigger, a bit small to do everything we want to do, which was another challenge and hardship. But I was happy with it. So it was a lot of work over 17 centers. So it was definitely, it could have been a lot more difficult. So the good things are we had sites participating, we had individuals, there was a lot of individuals who presented without getting information back to them. So they were altruistic and provided information to us. So, and it was successful. And then we had 17 IRBs say, yes, this is advantageous research. So I think there were some challenges, but again, I'm very happy with where we landed and what we learned from PRIMIER. We are thinking about a PRIMIER 2.0 where we will uncover and try to overcome some of these issues that arose in the first iteration.
Yes, so following with Dr. Che, she has a few more questions. So can we or other researchers have access to the research cohort that the uni hospitals, including Cornell Whole Health, are using on the learning healthcare system? That was question number one. And number two, do you have a separate dissemination team to provide the research evidence and tell them to the participants of your research?
Okay, so the first question was, is the data available? Is that what the question was?
Yes.
Okay, we are in the midst of deciding how that's going to happen, because obviously with identifiable data can never be shared, obviously, because that would be beyond the scope. So we are in the process of completing our first wave of papers with the PRIMIER clinics. And then at some point in the near future, we will, we're making the final decisions about making this data available to other groups, because certainly as part of our collaborative nature, we are open to collaborate. We want to make sure our colleagues who spent time doing this had the first chance to write papers on areas that were important to them. So that is where we are. And the dissemination team, yes, I think that will increase, as I think I mentioned before the talk, is we have 4 papers that now are ready for submission. One is the overall cohort, one is chronic pain, one is low back pain, one is headache, are all 4 that were presented at the International Congress, and they're getting ready to be submitted to different journals. We also have another paper that was presented at the Congress on obesity. So the first wave of papers are going out. We expect a second wave when we have our second wave of investigators. So yes, we're striving to disseminate this information both in presentations like today, but also in journal publications.
Mm-hmm. And another question, because we also mentioned that there is a limitation of a lack of a control group, do you think that we can maybe think of a step wedge design while designing a pragmatic clinical trial? Yes,
exactly. That's been coming up. So again, where we are, that's come up, I came up with NIH last week. I was talking to someone, and we were strategizing about step wedge, just because the idea of being able to, initially, we're considering step wedge. Exactly. Good question.
And then Dr. Shin, he said he really appreciates this presentation. We're sharing the interesting study. Many Korean researchers are trying to initiate PBRN studies nowadays. And he also has a few questions. First, he wonders what your team did for controlling data quality. He also wondered how your team dealt with the patient's other usage of healthcare, like since they are not in a trial, I guess that they might use other drugs during the study period. So he's wondering about this aspect, whether this was considered in the analysis process.
Sure. So data quality, I mean, certainly with REDCap as the premier, the patient-reported outcomes, we certainly had to ensure, by design, individuals could only complete one question, one answer per question. So the data quality with using Promise 29 via REDCap was inherent in the clinical structure of REDCap, so that was good. But I will say the electronic health record data with 17 different clinics and probably 6 different electronic health records was a lot of work. So one of the issues was we really had to ensure data integrity. We had our coordinating center at Einstein, and they went through for months. We had 2 different statisticians go through and ensure that both the condition and the interventions were coded correctly. So we did a lot of data quality with more of the electronic health record data. But we did range checks and validity checks with PROs as well. So we had statisticians that were working on that. What was the second question? I'm sorry.
And
Drugs use.
yeah, how did you control the patients using other healthcare? Like they might be using drugs during the study period, and did you consider this in the analysis?
Right. So we did ask about opioid use, opioid medication usage. We did, at one point we thought about using the whole electronic health record and going through lipid scores, weight scores, other medications, other care. Honestly, it became, it was too much information. So one of the caveats is there could be conventional medication happening alongside this. So again, in our papers, we talk about that there may be other things that are happening. We do ask each time at the 2, 4, 6, and 12, are they receiving integrative medicine, where, and all that other stuff. So we're trying to at least control for that in the analyses, but there are other things that could be happening. The same thing happens true in any randomized controlled trial, right? That people receive care outside of the trial. So again, it is one of the limitations of all research that patients can receive care elsewhere. We try to note that as a limitation and be very honest about that. We don't want to overspeak what we're saying. So we're trying to say there is a nice association. We need to understand more details about what's driving that outcome, and is dosing of interventions something that is independently associated with that outcome improvement.
Yes, and then by Professor Lim, he asked, was the big funding for this trial funded by NIH? And that said, all the funding aside, what would be a great motivating force, or how would you muster up the cooperation of all these institutions to do such a big study?
Yes, so actually the funding was not NIH, it was funded by the BraveNet Collaborative. So this was a philanthropic group. So the BraveNet Collaborative started in 2001. They launched BraveNet, the practice-based research network, in 2007 because we realized there was a need to collect outcomes across sites. So this was a group, a collaborative group that saw value in working together. But you're right, it is an expensive study. If we're thinking of PRIMIER 2.0, we're trying to figure out how to fund this approach. So when we moved to Connor Whole Health and Susan Samueli, those 2 groups will contribute resources to run BraveNet, but they won't be enough to have such a large multi-site study in the future. So we're working with NIH to see if there might be a way to take PRIMIER and propose a new study to them with this outcomes. Now, BraveNet is also running randomized controlled trials that are funded by NIH. So I have as I mentioned before, acupuncture versus usual care in 3 BraveNet emergency rooms. And that's an NIH-funded trial. It's a feasibility study just to make sure we can run the same protocol across 3 sites. But we're preparing now for a large grant application this fall to run a multi-site study to see definitively with about 800 patients, does acupuncture in the ER reduce pain and reduce opioid use relative to usual care. Another study that's being run across BraveNet is a positive psychology online course across 4 BraveNet groups, where we're looking to see, does a online positive psychology course for chronic pain patients reduce their chronic pain? So with a comparison group. So again, we are starting to run randomized controlled trials across the network, as well as our observational research, to increase our funding diversity, but also to get to answer different questions that are better answered in randomized control trials than in observational research. Great questions. These are fascinating, excellent questions.
And there's another question from Dr. Lim, and he says he's not sure exactly the year, but he believes that in 2015, the ICCMR conference, you gave a presentation on the effectiveness of acupuncture treatment for treating anxiety for heart patients. That was an observational study. Was there a follow-up study after that? If not, what could have been a reason?
And what conference was this? I'm sorry that it was.
He believes that it was the 2015 ICCMR conference.
With heart patients?
So cardiovascular patients.
This is my work at Allina Health, not at BraveNet. So at Allina Health, where I was for a number of years, we had care at the bedside. So this is inpatient, hospitalized patients. And we had integrative therapies at the bedside looking at, for cardiac patients, looking at changes in pain and anxiety. And we published a paper in 20, that's good memory. I've left Allina, so I'm no longer affiliated with that group. So I don't believe they're following up on that research. I do think the inpatient work is valuable, like we see in the outpatient environment, where integrative therapies that are introduced into that inpatient environment can have very profound changes over time, or changes on acupuncture and anxiety. So my team, using Allina data about 1 year ago, published information that anxiety and pain are significantly reduced when individuals receive integrative therapies. And in that case, we controlled for pain medications. So we weren't taking credit for narcotics or other pain medications. So we're very motivated not to take credit. Like, for example, in a hospital, if someone receives a narcotic at 8 a.m. and the integrative medicine happens at 8:30 and we collect outcomes, that we don't take credit for that narcotic. So we control for all those medications. And I'm very passionate about making sure that we're honest about what integrative therapies can do and can't do. So long answer, but I don't believe Allina Health is continuing to that research with cardiac patients, but there is value. Now, I will say at university hospitals, we are doing work with music therapy because we have a very large music therapy program. And so we're replicating that work in different populations with only a music therapy intervention. So working on 5 papers right now on music therapy in inpatient environments, in practice-based research.
That would be the last question. Any other questions? Maybe this is your last chance. It's also almost 9:30, so yeah, he should go to work and we should go to bed. So. 네, 질문이 없으시면은, well, 그러면은 I guess it's time to wrap up this webinar. Thank you, Dr. Dusek. It was very insightful and interesting talk. And I believe that people still have a lot of questions, but it's already 9:30, so yeah, we should close. Do you have any comment to add?
No, I think excellent questions. Again, the same things that I've been thinking of. So again, I really appreciate, I love the honest, open dialogue. I mean, does observational research answer all questions? Absolutely not. Does it answer a different question than randomized trials? Yes. And I think it's a complement. I think we have to pull all this together and understand where, depending on your research question, what style and what mode of research you use. So when I showed those bubbles, looking at comparison groups in particular patient populations, that's that red bubble, and that's the efficacy or effectiveness randomized trials. And again, I use those daily, so I totally appreciate all that. What we really liked about PRIMIER was what happens beyond the clinical trial. What happens when people use this in the real world? Can we routinely add in data collection to inform patients and clinical providers that information is oftentimes lost. And so again, has its limitations, has its flaws, but I think there's a value into showing people that if they adopt integrative therapies, there can be, for a certain population, a benefit to having relief of symptoms. And again, the question is, which patients, which therapies, what kind of dosing do you need? Those are very good questions that are the next steps.
Right. I totally agree with you. RCTs are not everything, and they cannot answer to everything.
Right.
So that's why we are more interested in practice-based research and observational studies. That's
right.
Things like that.
And there's a group in Australia who's also now becoming very interested. So the Western group in Sydney, they have a new clinic, and I've been helping them design some observational research. So I think there's some more practice-based research groups that are starting to be interested. And I'm happy to help any way I can your efforts in Korea, just because I think it's such an important thing for us to work together. And if there are things that we learn to PRIMIER that we can help you, we're happy to share, just because there's no sense making the same mistakes we made.
So if anyone is interested in his study and his methodology, you can freely ask him. Yeah, right.
Please.
For Korean researchers as well. Well, thank you very much. Somebody asked you to, you can share your slides.
Sure.
Would it be okay? Okay, then KMCRIC will send you the files. Okay.
Yep.
Yeah. Thank you very much. Thank you, everyone.
I put my contact in the chat.
All right. Okay. 그 이메일도 채팅창에 주셨거든요. 그래서 개인적으로 질문 있으신 분은 더 if you have more questions, you can email him. Okay. 그리고 KMCRIC도 많이 가입해 주셔서 다음에 또 이런 웨비나 기회가 있을 때 참석하실 수 있으면 좋겠습니다. 감사합니다. Thank you. See you. Bye.
Bye-bye.
Thank you.